So how do we put this into a clinical algorithm? Okay. Well, first, we do our initial assessment. So if somebody's had symptoms for more than 7 to 10 days, we call it PCS, even though it's not technically until 4 weeks. This is how we reduce it happening. We treat it early. So if it's 7 to 10 days and they still have symptoms, we're going to want to do a history, physical. We want to do any neurological examinations. If they have any neurological findings, we're going to want to refer that. Okay. If they have something where it's like, oh, you have this weird kind of ocular motor issue, you have a cranial nerve palsy of some kind, we're going to refer that out, right? Cerebellar dysfunction. We're going to refer that to a neurologist because they actually have a neurological problem. If they don't have any neurological problem, there's no need to refer them to a neurologist. There's no neurological findings. Okay. Then we're going to do orthostatic vital signs to look at what level of dysregulation is their autonomic nervous system. So we're going to do some testing in supine and standing. If they do have orthostatic intolerance, then we're going to start with kind of our POTS protocol. So we're going to basically shift them out of the concussion treatment program, and we're going to put them into a POTS treatment program to fix that first. Then we can start dealing with the other issues. Once we do all this, we don't have any neuro findings, we don't have any orthostatic intolerance. Now we're going to do education and reassurance. We're going to give them our diet plan to start working on the gut. We're going to give them sleep hygiene information. We're going to give them exercises for stimulating the vagus nerve to try and reduce that sympathetic tone, increase the parasympathetic tone. We have an app, so our software comes with an app where we have neurocognitive screening, we have balance assessments, we have daily symptom trackers, we have all these things that the patients do to optimize their recovery so they can kind of be involved in their own recovery. And then consider adding the Concussion Fix program, because the Concussion Fix program will also give them a resource that they can do all this stuff from home in between appointments. So it really helps when you combine those two things. Okay, visit number 2 then, we do our treadmill testing. If they've passed this orthostatic intolerance, they do their treadmill testing to figure out maybe they have moderate autonomic dysregulation. If they get symptoms with the treadmill testing, then we give them exercise. We give them subsymptom threshold exercise, and then we test every 1 to 2 weeks until they can do the test with no symptom exacerbation. And at that case, now they're able to return to any physical activity they want to do, provided it's non-contact. So that's kind of the split here. Regardless of what happens at visit number 2 on the treadmill test, visit number 3, we're going to do our vestibular ocular motor assessment as well as take a look at the neck. And now we have a good clinical picture of what's going on. Maybe they have a little bit of autonomic dysregulation. We're getting them to do some exercise, subsymptom threshold. We're retesting that every couple weeks. Maybe they have some neck issues. We're doing that. Maybe they have a little bit of vestibular stuff that we're working with as well. Now we have our treatment plan, and we're just knocking things off every single visit and gradually modifying things as things improve. Okay, that's the treatment process, and we're not missing anything.